Dear audience, what I would like to present you today is my PhD topic, investigations of halitosis. My name is Eszter Szalai. I am a clinical specialist at the Restorative Dentistry and Endodontics department, and my vision is to find and bring the best solution for diagnostic and managing halitosis to everyone. To reach my vision, my mission is to contribute to oral health and well-being by providing the best care to every patient. These are my first steps how I would like to achieve my goals. We will have to study with diagnostic and two with treatment corrections. So my first project, daily use of chlorine dioxide effectively treats halitosis. 60% of the world population has experienced halitosis, and 90% of all cases originate from the oral cavity. We spend billions of dollars a year on anti-malodor mouth rinses, but we still don't know which is the best. Or aim to evidence the effectiveness of chlorine dioxide in halitosis. Consequently, our clinical question, how do chlorine dioxide containing mouthwashes influence the level of halitosis? We would like to compare the chlorine dioxide to other mouthwashes or placebo, and our primary outcome, the changes on the organoleptic testing score or in the volatile sulfur compounds. On the first two forest plots, we will see the changes of the OLS. It means that the tester smells the patient's breath and evaluates it from 0 to 5, 0 when it's no bad breath and 5 when it's very severe. We can see on the first forest plot the one-day data and on the second the one-week data. It's visible that the chlorine dioxide effectively reduce the level of halitosis with almost one level. The heterogeneity is not really important in both cases. And when we measure the volatile sulfur compounds, we realize that the chlorine dioxide more effective on the hydrogen sulfide data. It's good for us because the main component of intraoral halitosis is the hydrogen sulfide. The heterogeneity in this case is substantially high, and we think the main reason because of Falmetol of the different rinsing protocol. So the strengths of our meta-analysis, that no formal meta-analysis from this topic. All of the included studies are randomized control trial, the Prospero registration, and the results of the organoleptic measurements in more time point. We also have some limitations, the small number of included studies, and we just find one eligible article with other comparator, which one was the chlorhexidine, and it seemed that chlorine dioxide almost as effective as the chlorhexidine mouthwash, which is the gold standard. So, what is the main conclusion? That chlorine dioxide mouthwash have to receive a more prominent or leading role in the therapy of oral halitosis based on our results. What is the implications for practice? We think we should use chlorine dioxide because of the unknown side effects, and we think that it will will facilitate more investigations within chlorine dioxide and the gold standard chlorhexidine mouthwashes, and it also can good for us because it will be or evidence is more better. So we are still waiting of the decision of the Journal of Evidence-Based Dental Practice. And let's move on my second project, which is the organoleptic method, not yet replaceable with device-supported measurement of halitosis. As I mentioned, the organoleptic measurement, this is the gold standard, easy to perform, but subjective, unreliable, and as we can see on the picture, it's uncomfortable for the tester and the testee. We have also other options, the oral malodor measuring devices, they are objective, the results repeatable and reproducible. The most used devices, the volatile sulfur compounds monitor, for example, the halimeter, and the portable gas chromatograph, for example, the oral chroma. Other devices also available, but our aim is to standardize protocol for clinical research into oral malodor. Our first project brings us our question, which of the volatile sulfur compounds measuring devices is most suitable for measuring halitosis? We would like to use the organoleptic measurement as the reference standard, and our index test will be the oral Marauder measuring devices. And we would like to exclude patients with systematic diseases because these devices measure just the intraoral halitosis. Our primary outcome, the correlation coefficient, and the secondary, the sensitivity and the specificity of the devices. Our hypothesis that halitosis measuring devices are as appropriate as the organoleptic method to measure the level of halitosis. After our systematic search, we made a full text selection. We find 75 eligible articles, and we could include in our quantitative analysis 65 articles. Our primary outcome is the correlation between the OLS and the devices. When we made the analysis, we realized that none of the devices is significantly superior to the others, but when we made the correlations with the gas chromatograph, we found that the Spearman correlation was 0.76, and it means this is the best device to measure the halitosis. But we would like to suggest to researchers to measure with gas chromatograph the halitosis, despite of disadvantages that it's complicated and so on. When we made the subgroup analysis, we found that the exclusion of patients with extraoral halitosis in case of sulfide monitor device, it caused better correlation between the sulfide monitor and the OLS, and it was 0.72. Our secondary analysis was the device's sensitivity and specificity. The device's sensitivity and specificity are not outstanding. It means that with these devices, roughly 70% of the patients can be correctly diagnosed. So, and also none of the devices is significantly superior to the others. The strengths of our meta-analysis is that no former meta-analysis from this topic, the high number of included studies, and the most used 3 devices included in our meta-analysis. We had some limitations, the low evidence because of the cross-sectional study design, the comparison with the subjective method, the low number of included studies in our secondary analysis, and maybe the inadequate or unknown threshold can cause also some bias. So what is the main conclusion? We think that none of the devices is significantly superior, not just in the correlation, but in the sensitivity and the specificity to the others. So it seems OLS still the gold standard despite of disadvantages. What is the implications for practice? We would like to suggest to clinicians that exclusion of patients with systematic diseases in case of sulfide monitor devices. And the 5th point scale is not significantly inappropriate, but we would like to suggest the 6-point scale. What is the implications for research? We would like to suggest to make more diagnostic test accuracy, because the correlation not the best method to measure the that is a good device or not. Need to investigate that OLS is a true gold standard or not, and we will hope that it will facilitate more investigations with newer devices, because we definitely need it. We are with our second manuscript before the language editing phase, and thank you for your attention. A bad mood is like bad breath, both are wrong to inflict onto others, from Dennis Prager.
I have one which should have been taken about 1 year ago. I wonder if you set a clinical trial and you would like to involve more investigators, you have to calibrate them. And right now you are dealing with organoleptic results from different investigators. So how can we say their observation are the same? I mean, the scale of bad breath.
Yes, we don't know exactly that it's the same, but
we hope. Yes, but we hope.
Yes, this is the reason that I suggest to need newer devices and need to measure that the OLS is the true gold standard or not.
Actually, in the field of TMD, investigations. There is an international network where the specialists are calibrated. So there is an international network for that. So it should be reasonable to do the same in halitosis field.
My question is related to the measurement of halitosis with gas chromatography. Is there a standard set of compounds that is measured by different groups, or everybody uses his or her set of compound, or is there any standard for this?
The sulfide monitors not separate the volatile sulfur compounds, but the portable gas chromatograph measure the hydrogen sulfide, methyl mercaptan, and dimethyl sulfide. So this is the main component that usually measured.
So correct me if I'm wrong, but in your first projects, you're dealing with compounds that are including chlorine dioxide. And as far as I saw, you don't have any safety outcomes. But chlorine dioxide is a very, very poisonous substance. Don't you think some safety outcomes could have been included in the meta-analysis?
Chlorine dioxide is not the same as sodium hypochlorite, so it's safe.
It's chlorine dioxide is safe?
Yes. Otherwise, we can't use for mouthwash.